Well, let's turn to the future a little bit and talk about, get our crystal balls out and talk a little bit about what we see in the future. Jay, could you talk a little bit about where you see MRD testing going and how we may continue to refine that?
So as you kind of started earlier, that MRD with this newer term with the measurable residual disease, and I think the level of sensitivity detection is getting better. So I think all the standard-wise, we're now kind of, we've been talking about 10 to the minus 4, and then obviously we have tools to get much deeper than that, to 10 to the minus 6, and I think probably even deeper soon. So the question will remain with the better tools, which we will definitely going to have, and how is it going to impact our current or our treatment? At the time, I said we're going to get a lot more data, but then the COG is already doing for those patients who are kind of 10 to the minus 4 negative, but kind of the NGS detectable or below, that should we changing those management for those patients or not? So I think the technology will get better. We'll be able to pick up these kind of the small level of a disease, and the more challenging is with what to do with that information. That small disease, is it worthwhile to intensify or change the therapy that has been previously working, or just continue with kind of what we do. So hopefully we can address these issues in kind of large trials to hopefully to really answer them rather than kind of borrowing the data from kind of the piecemeal. So hopefully that we can do that.
I think one of the things that is a drawback of these, DNA-based MRD detection methods, particularly in the future, as we start to bring more of these targeted immunotherapeutic agents earlier in the lines of therapy, those methods don't tell us about CD19, CD22 expression. It's not really so much of an issue if they haven't received one of those agents, but in the future, if we start using blinatumomab or CAR T cells or inotuzumab ozogamicin in the frontline setting, we know that those agents can downregulate expression of the target agents. So if we are detecting at these super low levels, but we don't know anything about the immunophenotypic features, we may give them blinatumomab, but there's no 19 there to target. So I think that's going to be one thing that, as a field, we're going to have to be sort of cognizant of and sensitive of as some of these methods. Not only do the methods get better, but these targeted agents get moved into therapy sooner.
There's something there, but we can't tell what's on the cell.
Exactly right. Exactly right. Yeah.
Interesting. Yeah.
I think that's actually a very important point because now we have a blinatumomab, and I think as you're alluding earlier there too, for the CAR T cell therapy, if they receive blinatumomab, are we going to be selecting a CD19, which majority of the patients don't, but there could be some settings. So, but I think you have to really kind of look at the plot sometimes, or have to talk to hematopathologists to kind of really kind of let them review the plot. And do you see any 19 negative clone, because you're worried, and that may change your management. So as these kind of the CD19 targeted or therapies are used earlier and earlier, I think it's important to really let the hematopathologist know that these patients receive CD19 targeted therapy. So therefore, that you need to add additional kind of the B-cell antigens, make sure that we target, especially for flow-based assay, and GSE obviously may not matter as much, but I think that's kind of the important point. And for the future MRD, I think hopefully we talked a lot about the bone marrow-based testing. I think as the sensitivity is getting better, what I'm also hoping is that we can move away from doing bone marrow so many multiple times, and some blood-based testing could be just as sensitive. I think that's kind of where this more sensitive testing can hopefully help our patients to lessen the amount of the procedures that they have to go through.
Yes, exactly.
Yeah, I think the data would suggest that it's about a 10-fold difference, bone marrow to peripheral blood, and if you can achieve 10 to the minus 6 in the bone marrow at that time point, then that would translate into 10 to the minus 5, which is more than sufficient, I think. So I think it's exciting, and I think generating more data to that regard might save some patients from some painful procedures, which would be great.